that we have as a country. We're talking about that aspect of preventive measures as opposed to curative measures. So keep it right here. Allow us to briefly peruse through the papers before we take a look at some of these stories that have been worked on by my team. Yes, we have the Standard newspaper, the People Daily, as well as the Daily Nation. And to begin, perhaps, is on the conversation of the prayers, and as well what is happening in terms of balancing the finances, and just looking at what the world then would expect of us, especially in relation of the budget. And so lawmakers increased budget by about 81 billion, raising it to 3.679. This is perhaps way up than the initial projections. And so we ask ourselves why. And we just look at some of the entities that have gotten the largest chunks. Yes, we're talking about, health as well as education. And as always, I don't think this is strange. Most of the times, you look at the budgets every year, they will, appear to favor the education sector and as well the health sector. But as they would tell you, well, some of these monies that have been accorded to them are never enough to sustain the health sector in the country. That is why in the course of a financial year, you'll see medics hitting the streets, strike. You will see teachers as well hitting the streets. And they say, well, most of the CBA agreements, or they have said, are normally not met. So even as we all understand that health is a devolved unit, it comes from the level, or the finances come from the level of the national government. And we ask ourselves, just how different will it be this time around, even as the government seeks to continue with the conversation of universal health care or universal health coverage. And so these are the budget estimates, as you can evidently see. We'll be trying to unpack them as we settle on health. As I have told you, I'll be having medics on board so that we can try and unpack this. So it's a conversation of the House, or in the House, and the committees are deliberating on these estimates. And of importance, we also have, that conversation from the people, and this as well is expounded on page 2, 3, 4, and 5 in relation to the budget estimates. Remember, so the 15th that it goes to the floor of the House, and we get to see what would be of Ruto's financial year. They have also constantly reminded us that, well, times are tough because then they're operating on the budget of the previous government. But this time around, they get their chance to balance their papers and make sure that, they change the situation for the people of Kenya. Perhaps the most expensive budget that we've ever had in history. And well, we have evidently seen, these estimates always going up by a year, depending on, the government that is on board. And so we ask ourselves, just what does this mean in a country where we're not able to generate the same amount of, resources or the same amount of monies, and therefore we cannot sustain our very own budgets? Well, will it result to more and more debt, or is this tax style of the current government going to be instrumental in making sure that at least we relieve ourselves from the numerous cases of debt? That is a question of wait and see. Calls for unity, peace dominate prayer breakfast. That also is the conversation that played out yesterday. We will try to, just remind ourselves of what really was the scenario. And in as much as there was that call for unity and as well for peace, equally, the tax conversation, did not at least got itself, into this whole conversation of prayer, as the president and his lieutenants also trying to remind the people of Kenya just how important it would be for them to adapt the Finance Bill 2023 and the proposals therein, especially in relation to the numerous taxes that Kenyans are complaining about. The conversation is on. I hope that you're part of it, because then it is your duty to be part of the very same conversation, because, well, when we're talking about taxes, then we are directly talking about the citizenry. And that also is one of the stories as captured right there on the question of education. Schools to receive funds tomorrow. Education Cabinet Secretary Ezekiel Machagu has assured schools that they will receive their capitation funds tomorrow. Remember, by yesterday, the heads of schools were threatening that, the possibilities of them shutting down are there, because then they are not able to operate without the finances. So perhaps this is a sigh of relief, and we seek to see, education perhaps, for our students managing to, school without having to go through these difficult economic times. That is on the Daily Nation. Briefly, let's see what the People Daily has, as well as the Standard newspaper. Front page of the Standard newspaper is on the question of the prayer day. Talk outshines unity, or tax talk, sorry, outshines unity talk, in spite of the theme of yesterday's prayer, which, well, we saw the opposition side boycotting. There was the conversation of reconciliation with God and men. Equally, President Ruto took, his time or his opportunity to rail at those opposing the finance bill, saying that they are insincere. So that is a conversation that as well we'll talk about this morning. Raila asks Kenyans to brace for themselves for protests. They say in the event that, well, this bill sails as it is, they'll have no choice but to mobilize their supporters to hit the streets. And on the other side, we're talking about this 80 billion shoot up from the original estimates of the budget. And so 80 more billion for Ruto to spend in ramping up a limping economy. And we're talking about budget estimates presented to Parliament yesterday show that the figure has gone up by about 80 billion shillings from the initial projections, with education and health taking the lion's share. Story captured on page 8. And as I have said, this morning we discuss health, and that in relation to the budget estimates, and finally what is likely to be presented for the financial year 2023-2024. Let's put an end to this madness in Shakahola. Certainly, that is what most of the Kenyans are talking about. And well, this story that has been captured on page 14, they say time has come for Interior Cabinet Secretary to Kithure Kindiki to offer the country a clear roadmap out of his inglorious spectacle of bi-weekly. And of course, we launches off the thing or another at the Shakahola Ranch. They're saying that, well, they should make it a monument or more or less entity. But, well, questions linger as to whether that is the right direction or not. But the conversation still is on. And unfortunately, we haven't gotten to the bottom of it. But then again, we will allow the agencies and the entities of government to handle this in the best way they know. The People Daily. Let's see what the People Daily has. And as it loads, perhaps you'd allow for us to look at some of the other stories that have been prepared by my team before I loop in the gentlemen that are already on standby for that very conversation. We said today we want to dedicate it to the question of health. We look at what devolution has to offer the health sector of importance. We make sure that we also understand whether the budgets then would be in favor of the health sector, and whether we're going to expect any form of changes and importance. Just what is the role of the unions in making sure that the medics get the best of what they could offer, and of importance as well, the people that they take care of. So let's briefly shift gears a bit, because then my People Daily is not loading. Allow us to take a quick short break, and then we come back with the news stories and as well as the gentlemen. All right, so today we're doing it a little bit different. I do not have politicians on set, but I guess in this country, because of the conversations that are on, we all find ourselves in a space where we can call us politicians, yeah? Because then you have to discuss the finance bill, which is more of an economic conversation, but then again, largely being discussed by politicians and decided upon by politicians. We have to discuss health. Health itself has been politicized for the longest time, I know. And we have to discuss education as well, find itself politicized, and perhaps brings us back to the acknowledgement that politics runs basically everything and anything in this nation. And so, gentlemen, you'll allow us to as well together look at the newspapers. And then after looking at the newspapers, then we'll shift gears to the main conversation. And the main conversation is on health and the budget. And so I look at the papers this morning, luckily, they are those projections as well as estimates that have been presented. And they are talking about an increase of about 81 billion. And they acknowledge that the education sector as well as the health sector are lucky to get the lion's share. I am not surprised about this. Perhaps even in my wildest of moments, if I'm to be told, think about what is likely to be on the budget. The first thing I'll always know is that education will take the lion's share as well as health. And this is what has been over the years. But even as these entities get the lion's share, they're the most bedeviled, I'll say, in the country, because it's the teachers that will hit the streets. Yeah. It is the medics that will hit the streets. So you ask yourself, why is it that these entities get the lion's share? Yeah. But most of the times you'll see our medics in the streets. Most of the times you'll see our teachers in the streets. Most of the times you realize that these are the very same sectors that are not making the best of trajectory. What informs this? So join us in this very conversation. And of course, be part of it. The hashtag is Morning Cafe at Linda_Lela TV47KA, and we'll be deciphering this as we continue with the broadcasting. Studio with me is Senior here. Senior, thank you so much for creating time. It's not the first time that Senior is here, the National Chairperson of KUKWA. It's a pleasure to have you this morning. Kenya Union of Clinical Officers, Asante Sana for creating time. Peterson Washiro, HSC, it's always good to have you. And right next to Peterson is Charles Okumu, who is the KMPDU Chairperson. That is Lower Eastern. Watu wa KMPDU wanaonekananga ndio wanasumbua zaidi. Wacha tuone leo kama itakuwa tofauti kabisa. Yao ndio wanasumbuanga, wanasukuma Union of Nurses na Union of Clinical Officers kusumbua zaidi. Right next to Okumu is Michael Saka, Kenya National Union of Nurses, right?
Yeah.
That is the Secretary, Machakos County. Asante Sana for creating time to be with us, gentlemen. So briefly, we all have the papers, eh? Yes. So we just look at the papers. Kidogo Juju, perhaps the first pages, and from that story of the budget, then we pick our conversation. But yes, to once in a Daily Nation, Sindio?
Daily Nation.
To once in a Daily Nation. You know what was standard, eh? Everybody had fixed the standard fast. So here we are. The first story is on members of parliament, World Bank World Ruto on tax. That aside is what will trigger our conversation this morning as we look at the numbers and what the health sector then gets. But we also have this conversation on the prayers. First of all, what did you make of the prayer moments? I had some people here yesterday who felt like, we are being hypocritical at this point in time. Yeah. But then again, is it not a requirement, first of all, of the Constitution and as a nation, just to get ourselves into the moment of prayer, acknowledging that, yes, we have shortfalls, but then again, there's a Supreme God who's supposed to take care of basically everything, just like everybody will make noise and then they'll come back to the chairperson and say, Chair, now what do we do?
Yes. I think what I would say, and thanks a lot for inviting us and even for this very important conversation about health. I sometimes feel that we don't have it enough times as we should, and we are really grateful whenever we are invited to such a platform.
Thank you.
My expectation was that the prayer breakfast would have been a unifying call to come together and discuss. I was expecting them to quote that verse in the Bible, I don't remember from where. Come, let us reason together.
Yeah.
Because it is obvious that we are reading from different scripts that the workers, and especially those at the lower strata of the salaries, are really feeling that they are the ones who are carrying the burden of this budget. as per the Finance Bill 2023. And there has been an outcry across the country, not only for workers, but even for other people who are operating businesses. And there is a lot of anxiety. So my expectation yesterday was not met, because my expectation was that in that mood of prayer and unifying, I was expecting that there would be a call, that we have heard you, and because God wants us to come together and reason together so that we can live harmoniously, that there would be a call to the committees involved. Can you then sit and try to make reasonable adjustments so that you can be able to be in line with what Kenyans want?
But the bill hasn't gone through the full cycle, and there's that pace in Parliament. Perhaps it's going to be, I don't know, don't you have faith that somewhere along the line, maybe this wasn't the platform for it?
But we have heard what they have said. We have heard from people who speak on behalf of the government in terms of politics, saying they are not going to change even a comma. We have also heard from the president himself saying that our people, that is, our MPs have to toe the line and they have to pass this deal. But we haven't had any compromise. And that is what we have been expecting, because as a leader, and when you are leading people, it's not everybody that is going to be of the same mind. You must then have a way of bringing everyone to the table so that you can reason together and you can come to an agreement. Yes.
Okay, well, this is quite interesting, and that is Chair's position. You could be in agreement to some of the components that sit in the finance bill, you know, and therefore you could be having a different opinion. I know you as well represent very many faces. What are the voices like in terms of, you know, what these other medics think? Should we, and I know a majority of them have argued that perhaps we might not need the housing levy and all these other things. Do you maintain the same position as Chair? Is yesterday, or yesterday could have been the best platform to address this?
Thank you, and it's my pleasure to be here.
Karibu.
I want to first agree with my colleague, but on what he said, but also to come onto the issue of the national prayer, just to begin with that. You know, we are a God-fearing nation, and so I think even in our own families back at home and wherever we live, prayer is something that we all take seriously. So I think the idea of national prayer breakfast has always been a welcome one to the large extent of the country. But then I also think the Bible, from where we draw all our faith, explains to us very well that faith without action is dead. Therefore, we cannot only just keep praying all the time. We have seen prayer breakfasts held this year, even last year, and I think even the other year. What is obvious, though, is that there has been a public outcry. We have seen with the beginning, even before the finance bill was cast rolling, or before the voices were loud enough, we have seen a lot of issues coming up, especially cost of living and all these things. And we've always seen a public outcry. Now, coming onto this other side of us in the healthcare, who represent all these issues amongst our doctors and nurses and so on and so forth, we've seen similar public outcries. So for the first time in this country, we are seeing that the so-called professionals and the so-called hustlers are actually speaking the same language, and that is difficult livelihoods, cost of living, which has never happened before. So we see rising fuel prices, and then we hear of the levies that are being introduced. And I will tell you, from where we sit, hardly 1 week ago, we had a gathering of healthcare workers, doctors included. And this was an annual general meeting. And from this meeting, the message was the same. And the message was that we have seen the proposed taxes. We have seen all these proposed NHIF increments. But one thing that the workers will tell you is that how comes the cost of living has gone up, my salary has not gone up, my benefits have not gone up. So for the last several years, we have not seen any change on this salary. But then in very few months, we see a lot of changes in terms of NHIF subscription, a lot of changes in terms of, or proposed, so to speak, in terms of housing levy and all that. So I think this has brought a generalized anxiety and also fear amongst these workers. So the prayer breakfast was good, but then you'd expect that such issues that come out publicly through various platforms that we have, even in social media, these issues come out. You'd expect that at such a national prayer breakfast meeting, we would walk the talk and actually live by what the Bible says, that faith without action is dead. And as a leader, His Excellency the President should listen to his people, because the voice of the people, again, is the voice of God.
All right.
Yes.
It can be quite confusing for His Excellency, I assume, because there are some people who will say we do not want the housing levy. There are others who will say then we want. So at this point, it's quite a delicate balance. Why do we assume that a majority are against the finance bill? And I'm looking at some of the papers this morning, and they try to highlight some of the key things that would appear as though are gains within this document, and others that are more of pains. And pains, of course, we have capitalized on the 16% VAT on fuel. That is from 8%, 3% housing levy, 15% withholding tax for digital content creators, 15% excise duty on mobile money transfer charges up from 12%. They're looking at some of what you would consider as gain, 50% excise duty on banking money transfer charges down from 20%, 15% excise duty on airtime and data down from 20%, reduced prices for medicines due to incentives. Medicines, underline that because that is part of your, concern or your interest. Refund of overpaid taxes in 6 months down from 2 years, and a couple of other things that sit therein, and as well the budget highlights here. Your opinion on what played out at the prayer day yesterday, but of importance, is it not a delicate balance for the president, if not members of parliament?
Thank you for the opportunity. I would like to say this, as my colleagues have indicated, prayer from where we come from, it's based on family. Prayer has always helped us sort a lot of issues. So we're expecting to see our president as the leader of the nation, and someone whom we've known to be prayerful with his whole family. Same applies to the second family. So we expect them to walk the talk. Prayers in this country has been turned to something like hypocrisy. You meet, you pray, and then you don't even act or behave like people who have been from a prayer. So when you look at the budget, the pains are more than the gains. I would like to say this, like for the housing levy, the 3% housing levy, most of our workers, most of our members have already either taken a loan, bought a plot, others are already taken mortgages. You see, like when you look at civil service, most of the time you'll take a loan, buy a plot, buy some time, take another loan, like a top-up, and then you put up your house. Now, if you're told to pay 3% for 7 years, and you're already past 40 years, will it really benefit you?
Perhaps not, but then again, they say they will refund in the event that you do not want a house.
So we are looking at this thing, at the whole thing this way. A health worker in Turkana paying 3% for a house being constructed in Nairobi. Is it really helpful to the worker?
Most likely not.
It's not helpful.
But they try so much so to articulate and explain how then you get to benefit and all that. And all these questions arise, well.
We want this thing to be made open. It's very opaque. Who are the investors? What is the plan? So that's what we're asking. The previous government, I would like to say this, was able to put up houses without this levy, the 3%. Because it's not even a contribution, it's a tax. So as they pray, they should also pray for the local mwananchi. Also pray for our payslip and implement whatever the unions are talking about. We want a positive increase in our pay so that they can go ahead and tax us. Like what we saw with the Kibaki's regime. We're able to get allowances. So when you're given allowances and then you're later taxed, you're not able to feel the pain. And also, as we also talk about the pains and the gains, we are seeing a government which is delaying even in submission or remittance of money to the counties, payment of salaries. How safe are we with our 3% deducted from our salaries?
Right.
And also the fuel, an increase in fuel, the VAT, it cuts across fuel cuts across everything. So we are looking at, what are we looking at? We're looking at an increase in our fare, food prices, any commodity which will be produced. So basically, the pains with the financial bill or the Financial Act 2023 are more than the gains.
Wow.
Yeah.
At what level are we able to make adjustments as chair here would propose? That is basically what is ongoing. Allow us to take a quick short break, gentlemen, and then we come back and pack some more on what the papers detail, but of importance, it is about the health sector. I repeat, the role of the unions and of importance, the aspect of devolution and as well the budget, even as health is amongst the entities that gets the highest of chunks. We take a quick break, we're back. All right, we are here with medics, gentlemen that represent the numerous unions, in the health sector in this country, and we try and unpack, what the papers detail this morning. But of importance is the health sector. We might not want to, try and unpack the numbers just yet because we're still waiting for the budget to be read. But then with the projections that are there, we can as well have, a tangible conversation revolving around that. But of importance as well, we just want to understand the importance of unions and making sure that the health sector is well streamlined. And equally, this conversation of devolution, as they always remind us that they would love to have, health back to the national government as opposed to the devolved units. But is that really going to serve the purpose? Is that going to bring the change that we have envisioned? They say they would want to have a health commission. Is that what then would bring change? When you look at the teachers with the Teachers Service Commission, and most of the times, the complaints are still in existence. So, gentlemen, allow us to go back into this very conversation. It is Wachira, it is Saka as well as Okumu, as we discuss this. So we are just trying to look at the numbers. Well, not much of the budget and what the estimates are there, but we all understand very well that the projections are at that level. We're trying to castigate the prayer moments yesterday, but we also appreciate that, well, at least the nation acknowledges and the leadership acknowledges the importance of God, in all this. Some of them decided to boycott because they would argue that it's a lot of hypocrisy. But all the same, here we are. And I'm looking at one of the stories on the Daily Nation in relation to health. They say illegal revision of tender document casts a shadow over 7 billion NHIF deal. NHIF in itself, most of the Kenyans will tell you, in a language ya kawaida, is a scam. I don't know whether. What do you make of the NHIF?
Let me start by saying that NHIF is a good thing. Any socio-medical insurance is a good thing because its main objective is to ensure that that of affordability of health services and that you prevent your people, and especially the low socioeconomic status, from what we call catastrophic medical expenses that probably will push them into poverty. Now, when NHIF, I think, was put in place, was established, that was the objective. The problem is the management of NHIF has not been as transparent as it should be. And we have seen over time, NHIF has been infiltrated by political interest. Most of the time, they are controlled from outside. And I think it would be very good if NHIF would be an independent body that does not directly receive commands from the executive, and that can actually stand up to the executive and say, we will not be able to do this, our work is
that not how it should be? It's just that...
Yeah, that is how it should be, but that is not how it is. And the reason as to why I'm saying this is because as Kenyans contribute, there is an expectation that they have been having. But except for probably a few of the civil servants and those in some superior schemes, anybody who is under whatever they call super cover, and super cover extends to that person who voluntarily pays their 500 shillings to somebody paying 1,700 shillings, but they are not in a negotiated cover, that it is very hard for them to be able to access standard medical services from a standard hospital, because most of the standard hospitals, I'm not even talking about the high-class hospitals, I'm saying as standard hospitals, most of them will not accept the super cover because either the rebates are too low for them to manage or the NHIF simply does not pay. Like now we know that hospitals are actually owed up to 20 billion in money that has not actually been reimbursed for the services
recently
they have been able to
I was going
offer.
through a story, and it's basically the country that most of them have decided that they're not going to take any NHIF patients anymore.
And what that means to Kenyans is that for that poor family with a cancer patient that cannot be able to take their patient to a hospital that uses NHIF because of the failure of NHIF to rebate, is that now they are going to sell their land, they are going to sell their property, and we are pushing them down below the poverty line.
Yeah.
And that is the issue we actually do have with NHIF. On one side, you are telling us, can you please increase the contributions to 2.75? And on the other side, we cannot access because NHIF is not up to its task.
Yeah.
If you look at the 2.75% that we are talking about, for somebody who is earning, let's say, 100,000, that will come to 2,750. For somebody earning 200,000, that is about 5,500 per month. If you look at that money per year, it can get you a good cover with any private insurance that will be able to take care of your family. So what is this package that now NHIF is going to offer that is different from the others?
Yeah.
And you know, the concern of Kenyans as well as ourselves is that this money, the money in NHIF, it should actually be ring-fenced to ensure that it only goes towards health services. But sometimes we have seen that probably this money is not used for that purpose, because right now we cannot understand. I'm sure you were deducted NHIF in your last pay. Why is it that we are not able to pay health facilities which have already offered services? That can only mean that that money must have been diverted to other businesses. And that is why we are saying NHIF then, if we are going to give them this money, there must be some reform to ensure its independence and to ensure that they can actually be able to appropriate this money in the right way.
Right.
And the right way is to meet the objective of ensuring that Kenyans are actually cushioned from the catastrophic medical expenses. Yes.
All right, wait, so here we are, and beyond NHIF, there are lots of insurances, and while they work in favor of that, just what is, you know, the medical fraternity then equally doing to make sure that some of these arrangements that are in existence work for the people?
Yeah.
Because if we're going to sit down and, you know, keep complaining and pointing a finger of, you know, at the executive for perhaps interfering with the activities of the NHIF, what are we saying in this, in essence?
Thank you. Yeah. First of all, before I even go to what you are saying, let me first of all say that the whole NHIF idea was a very good idea. But the framework and the circumstance in which it works, I think, is not ideal.
Yeah.
Why do I say that? Because NHIF is a public entity. So there are two issues here. We have a public entity, that is NHIF. We have the public hospitals.
Right.
And on the other side, we have the private hospitals. So the first fundamental question we want to ask ourselves is, why is a public entity serving private interest? So an ideal situation would have been, and if we draw from the NHS of the UK or these other countries, you are able to see that a functional healthcare system has the equivalent of an NHIF and a well-funded public healthcare system. That is what happens elsewhere. And so, therefore, you have, let's say, for example, a government that is able to fund the healthcare of that country to an extent that now the private, the players like NHIF now are able to reimburse those services in a manner that is affordable to the NHIF itself and also is affordable to the contributor of that scheme. What we see here is healthcare is expensive. So the contributions, according to NHIF, if you were to sit on the other side of the NHIF, then you might see that their statement is that the contribution is not enough. Yet we all know that it is more than enough, and probably it is not being used prudently. But then the conversation still should be like, NHIF is a public entity and would only function effectively and appropriately in a public-funded system of healthcare, so that the costs are met by the contributors, that is the the patients through NHIF, and on the other side we have a government that is meeting the other half of the cost. But now what we have is a public entity that is receives contribution, but is attempting, if I can use those words, attempting to pay for services in private facilities, which I think actually takes the biggest chunk of NHIF contribution. And we all know that healthcare is expensive, not
Right.
just in Kenya, but also elsewhere. So I think that's where the problem, first of all, lies.
Yeah.
We need to restructure the whole NHIF so that we have government, because the taxes we pay as you earn, and all these other taxes that we do pay, that is how government is supposed to meet NHIF halfway in a properly funded public healthcare system, so that NHIF now can pay. Then if someone envisions to have maybe a private cover, actually in a well-funded public healthcare system, the private healthcare does not exist, because everyone is happy to go to Kenyatta National Hospital and receive services as they should. Everyone is happy to go to Machakos Level 5 or Migori and receive the best healthcare. And in that case, then you don't have problems of NHIF still saying that we don't have enough contribution, therefore we need to revise your contribution to 2.75. In that case, you don't have a situation whereby people are complaining that we are contributing too much to NHIF, but we're not seeing those services because the government has already funded these health facilities, and your contribution actually as a patient or as a contributor might actually come low, because now that is a properly functioning healthcare system. And for us in the unions, the various unions that we represent, I think for us, number one is advocacy. We try to advocate for some of these changes. But again, sometimes it does not really work. In the places where we work, in the hospitals, we try to make sure that the funds that come from NHIF actually are used within the facility. One challenge that I will tell you, and I'm sure my colleagues have also experienced this, in the current system of reimbursement of NHIF, especially at the county level, you find that the funds generated from the hospital, so let's say a patient comes and is seen today in a public hospital, those funds that they will be charged and sent to NHIF if they were subscribers of NHIF, initially these funds used to come to the hospital accounts, such that now the monies from the NHIF are ready within the hospital and accessible within that particular hospital. And that would help in certain ways, because you find now if maybe the casual laborers of that hospital were not paid, there would be a way they would be paid. If there was a gap in gloves or medicine, those would be paid with such things. But now what we have currently is that if the same patient comes and they are treated, and that money is invoiced to NHIF, when it comes, it doesn't come to the hospital account. It goes to the county account. Now what that means is that the moment that money hits the county account, then the hospitals lose track of it. Yet it was generated by the same hospital that is now losing track of it. Therefore, this money will find itself being spent in areas, let's say, for example, road development or other things, which is okay to develop a road, but
then
if
again,
it was
at the expense
of a patient who subscribed to NHIF. So these are some of the discussions we've also had with the various stakeholders so that we can find a way. And I know, for example, a county like Kitui has attempted through the county assembly to come up with a bill to sort of ring-fence this fund, so that now when you have money being generated by the hospital, it comes back to the hospital. That's why you see most of the time you hear, hospitally, we are running short of drugs and so on and so forth, because there has been that gap. Once that money comes back, the hospital does not access it.
You know, Saka, this is quite unfortunate, and I'll tell you that the very few or many years that I've been in the media industry, I have discussed this very same factors, you know, and discussed it with unions, discussed it with CEOs of various entities of education, discussed the same, you know, with the CSs of Ministry of, you know, Health. And you ask yourself, just where is the gap, such that the conversations are on. Even members of the NHIF, I have engaged. And, you know, these are always the matters that are of concern. When until we realize universal health care or coverage, when until we have some of these concerns that are here being raised, you know, addressed, and especially when we say that even as unions you have tried to, you know, lobby and speak of this was in vain, does it then mean that we also lose hope in the existence of unions and representatives?
Oh, thank you. Let me first start by saying this. Healthcare, to achieve a good healthcare system, we need to look at 4 pillars: information technology, human resources, management, and finance. So for NHIF, it's not supposed to be, what we're saying, it's not supposed to be called even National Hospital Insurance Fund.
Yeah.
It's supposed to become a scheme.
Okay.
So we need to target the households. Let's get the households. Let's stop targeting the pay slips. We need to increase the number of contribution. Data from the government indicates right now there are around 12.7 million registered members. But how many are contributing? Less than 2 million. What is not happening? We need to target the households and leave alone the salaried people so that we can be able to improve the contributions to NHIF.
Right.
That is one. Two, NHIF needs to be reformed. I'll give an example of our county. We have deducted our salaries, our deductions from our salaries, remitted on time. Right now, as I speak, Machakos County has already remitted for May. And reimbursement takes how long? More than 3 months. What's happening? So these are gap. That delay in reimbursement.
The remittance has been done, but then the reimbursement takes forever.
Takes a very long way.
Why?
A very long time. That's why we're wondering what's really happening. So with that gap, services do what?
Delay.
They are
And
delayed.
not according to the people.
Yeah, and then there are issues which come up. No, so what you're saying with NHIF is simple. Let there be reforms. Let's stop the political interference.
Yeah.
That's happening at NHIF. When you look at the previous act, which was signed last year by Uhuru Kenyatta, it gave a leeway for employers to pick any other service provider.
Yeah.
What does that say? The government itself, it has no trust in NHIF. Yeah. Yet it's supposed to be catering for the local mwananchi. Look at our hospitals, our major hospitals, Kenyatta, MTRH, even GTRH. It's now even closing. What is NHIF doing about it? My colleague has talked about ring fencing. We had a conversation. I think this is a conversation we need to have with also NHIF and the other stakeholders. Money sent back to the facilities should be ring fenced for medical care. It's a policy which is supposed to, we need that policy in law so that whosoever interferes with this money can be prosecuted.
Right.
Because it's been diverted. And it's been diverted at the expense of service provision. Like Dr. Okumu has talked about it. I'll take the example of dialysis. Most of the services under dialysis are fully funded by NHIF. And when you look at the UHC program, plus the equipments and the rest, they were able to, they were able to set up dialysis center. Like where I work, in Machakos County, we had a good dialysis center. What happened to it? Patients come, they pay via NHIF, money comes back, it's not ring-fenced for dialysis. Ends up being diverted. When the patient comes back, there are no supplies, no medication. What's really happening? So NHIF needs to be reformed, that is one. We need NHIF to be, as I've talked about the pillars, the 4 pillars, information technology. Let it be accessible to the local mwananchi. So that using my phone, I can be able to access and know these services which are available. This is the amount of money I've spent. There's some form of fraud going on at NHIF. It's interesting. When you check to confirm whether you're the only beneficiary, you're the principal member and your beneficiaries. At times, we even get a different beneficiary. Using your card. So the information technology or the information system at NHIF
has to be worked on.
Has to be worked on.
Okay.
Management is a problem at NHIF because of politics. And when you look at the financial bit of it, it's not a matter of increasing our contribution from 1.75 to 2.7. Yet, majority of civil servants are between job group A to K. They indicate in quotes that your services are unlimited. That is one. Two, which is quite unfortunate, our members are forced to pick a facility A specific facility.
facility,
So if I'm in Nairobi right now and I picked a facility in Machakos, I'm
You have to
unwell.
now think of how
Yeah.
you either get to Machakos
Yes.
or make adjustments. I don't know how
Yeah.
flexible it is to make adjustments, by the way.
It's very difficult.
It's very difficult. It's
It's
quite a
very
hassle.
difficult.
I
It's a
think I'm
hassle.
a member of NHIF, and not out of ignorance.
Yeah.
I think it's the struggles. I haven't picked a hospital just yet.
Yeah.
And I hope that I do not get sick. I think the heavens have really been good to me. You really look at the document, you are confused. You go into some area, you really do not understand whether you understand that facility
Yeah.
and whether it is good. What is even the guarantee that you'll go there and you will not be sent out? It's quite...
It's quite a hassle.
troublesome, I
And then
have to
when you
agree.
visit the same facility, maybe the much you can get is consultation. You're told your cover can only, it limits you to consultation and maybe some few investigations, laboratory investigations.
Yeah.
So it's not working for us.
Well, okay,
So-
but I'll also acknowledge the fact that I have had a patient who really got, a lot of benefit courtesy of NHIF. In as much as it was troublesome in the first phases, eventually they got help courtesy of that.
Yeah.
And so we also have to acknowledge, if worked on proper, like you rightfully say,
Yeah.
then it becomes a very good scheme for us.
Yeah, it's supposed to be a scheme.
If at all, we're going to make it a scheme.
Yes.
All right, gentlemen, we have to take a quick short break, but maybe a minute or two. KEMSA, because as well, KEMSA is on the newspapers, was there yesterday and is there today.
Yes. I think the same
KEMSA
problem
is a whole
the same problem bedeviling
NHIF is the same.
same.
It's the same in KEMSA.
Yeah.
Yeah.
We must ask ourselves, how comes that with different administrations, different people in administration at KEMSA, we keep having the same thing?
Yeah.
What drives these scandals? Why is there a lot of political interference? Because sometimes it even seems like some of the scandals are actually manufactured for political reasons. And I'm not saying that is what is happening.
Yeah.
But there is a lot of political interference. We saw the issue of COVID millionaires, most
Yeah.
of them being politicians. And that's basically our problem. So if we really want these institutions to work for us, we must get rid of politics from the administration of these parastatals.
My assumption is that, for instance, let's start from the level of President Uhuru Kenyatta, who, was pushing for the 4 pillars to make his government a success, and healthcare, universal healthcare was amongst them, or universal health coverage was amongst them. Why would a leader really push to make sure that, the health sector is well streamlined for purposes of posterity, for purposes of, his or her people, only for them to again join in and sabotage politically?
I think because of people have different selfish interests, and the problem with us as Kenyans, and especially the politicians who are just a mirror image of ourselves, is that we have seen some levels of selfishness that will surprise you. How do you sell out contaminated sugar that has some elements like mercury that are going to cause cancer. And
you know
it's
very
common
well that-
knowledge out there
Yeah.
that this is what is going to happen in the next few years. But then somebody can get that sugar and sell because they need money for politics or whatever reason.
Yeah.
And they're still politicians, by the way. It's the politicians who actually did that.
Yeah.
So our problem is selfishness. We don't have virtues as a country. Not only politicians, because we are the people who elect them. The most corrupt is actually the favorite for the mwananchi. So it's not only a problem of that politician, it's also a problem of which virtues
Society.
do we look at when we are electing the leaders that we take into office. And as long as that does not change, then we are also not going to see any change, whether in health, in education, or in any other sector.
Okay.
Yes.
All right, so that's quite interesting. I'm told we can proceed. And like we all agree that perhaps the same problem that bedevils NHIF sits within, the KEMSA and many other entities. Let's talk about the unions before we come to the budgets, before we come to the counties. Just what is the essence of the unions? And I know if there's any, I would want to say, crop of unions that is quite vibrant in the country is, the unions of the health sector, and that we cannot dispute. But even with the vibrancy, do you suppose the medics are getting what they would, require from the unions? Sometimes we have had the medics hitting the streets, oh, things are not good, things are not well, and they call upon the unions to speak on their behalf. Before you know it, the unions are silent and their cases have not been addressed. Then you hear that perhaps it was the brown envelope, or unasikia wamepewa kitu wamenyamaza. And we report on these matters, and you can almost get yourself trusting what these medics are saying, because there's no way someone can be on TV, on the platform, complaining so hard today, and the next day it is total silence. It's even quite unfortunate that the union leaders today are politicians. Not Secretary General, former Seth Panyako. Seth Panyako is under you. Is a typical politician. So sometimes you get to ask yourself, what is the essence of the union? And that's fine. I think it's almost the same, kind of behavior across the global fraternity.
I will say this. Thank you. Let me address it easily. Unions are there to bridge a gap between the employer and the employee. We immediately focus on the employee's welfare. And we receive them on even an hourly basis. There are some you can sort spontaneously. There are some which require some compromise. Some, as you sort the issues, you have also to negotiate. You get my point? Yeah. Same way our leaders up there represent us, like the way we've seen with the former Prime Minister. Yeah. He had to compromise and have a handshake for the benefit of the country. So as leaders, as unions, what we've been doing for our employees, we've been addressing the issues which have been raised. Those which can be sorted spontaneously, we've been doing it. But the issue of the brown envelope, and maybe money changing hand and the rest, I doubt for a passionate union leader or unionist, that thing can ever happen. Because that will be at the expense of your employer, who is your member. Because right now, as we speak for our members, they make contributions. They have deduction from their payslip. So they are the ones who are facilitating you, not even paying you.
That's true.
They're facilitating you to present their views to the employee, to the employer, sorry. So there are issues which we'll be able to sort immediately. I want you to understand these. The ones we're able to sort immediately, like you call me right now, you have issues maybe with your superior, we call your supervisor, we discuss, we sort it immediately. Issues to do with promotions, issues to do with salary increment, they are budgetary and they have a monetary effect. So you have to negotiate them, and it may take time for the negotiations to happen and the implementations to be done. So where we are as union, we believe whatever we've been doing for our members, especially in the health sector, has been very impactful in their well-being, both professionally and socially.
Okay.
Yeah.
You are confident that the unions are serving the purpose?
Thank you. Yeah, I think the unions still have a key role. Yeah, and just like we have said, NHIF and KEMSA, we've seen their strengths and weaknesses. Unions also have their strengths and weaknesses. If you look, for example, how the unions came about, because of, the money owners versus the workers. Yeah. Okay, so at some point, the unions came about as a compromise between these two entities. And that means, even to date, you will see what used to happen then when the unions were coming up, still happening today. What used to happen then was that the money owners would always look at paying the workers the least wages. They would always ensure that the working conditions of the workers then were the poorest. They would ensure all these things that would favor themselves, but not favor the workers. And that is why you see now the fathers of these things we call unions and so on and so forth. That is how these people now sprang up and actually came up with this idea of unions. And we still see that to date in the counties and even in the national governments. We still see situations whereby salaries are delayed. Not so long ago, we had a few counties staying with salaries of workers for more than 2-3 months.
Yeah.
Yet these workers have to work every day. They have to show up, they have to look for transport, and they have to eat at work.
Yeah.
So that is just an example of how even previously, before unions became what we know them today as, employers used to do. At the same time, we find the same counties not paying are also not promoting.
Yeah.
Yeah, so you find that as a doctor or as a nurse, you have an entry level, and then you are supposed to graduate.
Yeah.
Maybe after 1 year, based on a schemes of service that actually is a government policy document. It is not designed by the worker, it is designed by the government in consultations with the unions and so on and so forth. So you find that these same employers of today, they borrow from the same oppression that the employers of then used to have on the employees. And that is why now the unions actually, in my view, are even more relevant today. Because now the issue today is that we have increasing cost of living. We have challenges. We have people with psychosocial issues and so on and so forth. So now the unions try to, first of all, safeguard what has been kept.
Yeah.
And that one, we try to do it through the various CBS. You realize KNUN, beat KNUN, beat KUKO, beat KMPDU. Usually there's a collective bargaining agreement. And the whole essence of that is to try and safeguard what you have. Because you know, based on that philosophy of the employer or the money owners always coming for what the workers have, the workers fear that these people on any day, they might come even for what we have gained. So therefore, we must agree with them in a document and register it in court so that we feel protected. That is number one. So safeguarding the gains.
Yeah.
And number two also, you find that as you safeguard those gains, you want to see if you can also tilt the scale. Because it's always a seesaw, it's a beam balance. So the capital owners on this side and the labor owners, actually, it's labor versus capital. So it's always on a balance. And as you keep what you have, you want to see, how can I negotiate better with my employer?
Right.
Can I get my promotion in time? Can I get my study leave? Because healthcare workers always have to keep improving their knowledge.
Yeah.
So these are some of the things we have to always seek for. Now, coming to what you raised about the change. One day this...
Chair, allow us to
Yes.
take a short break, a quick one,
okay.
and then
All
we
right.
come back to that aspect
No.
of change. All right, so okay.
You are watching TV 47, the home of untold stories. It's fight night, and the WBF title is on the line. 10th June at Charterhall, Nairobi. Sarah Achieng defends our national hopes against Edith Soledad from Argentina. Event begins 6 p.m.
All right, and we have in studio different leaders of different unions in the medical sector, the KMPDU, as well as Kenya National Union of Nurses, and as well as Kenya Union of Clinical officers. You know, this ones can be quite of tongue twisters. Yes, Wachira, Okumu, as well as Saka. We are trying to unpack some of these things that sit in the medical sector, and we might not go in depth into it, but I think the basics of it will keep the conversation going. And so we come back to you. There's something you wanted to speak about, the challenges that sit therein, and the unions and how they handle them.
Yeah, thank you. So I think, of course, we've seen challenges, like you have mentioned, with exchange. Sometimes we say this and then overnight, so to speak, there's a compromise. And I think I like what my colleague said. I think sometimes when you are pushed to the wall, then you realize that you have to take a compromise. Usually it's a negotiation. And we have seen this even with our national leaders when, for example, he mentioned the handshake. I think that is the same exact thing that happens. Because when you cannot push your employer, then at some point, and they cannot push you, then both of you have to have a settlement. And I don't think it always means a brown envelope. I think when it is a brown envelope, then now that really begs to the question of the whole sense of the activity. I think what we have seen, from where I sit at least, is just an honest negotiation. Okay, sometimes there's dishonesty with part of the employers. They tell you we'll do this and then they don't do. But hardly do we see exchange of envelopes, from where I sit. But the other challenge I think unions, the various unions experience, is maybe blackmailing. You find that unions depend, union activities are usually dependent on membership contribution. So sometimes the employers, they don't submit that contribution to the various unions. So you see now that in that way, logistically, you're paralyzing the activities of that union. So if an official needed to reach a place to sort out an issue, then that becomes a challenge. So that is the second challenge I would mention. And of course, the most obvious challenge are the issues of victimization. So we have seen incidences where many union officials have been victimized for various reasons, for maybe taking members to industrial strikes, or for standing firmly against an oppressive act. We have seen that happening. And these are challenges that I would believe all union leaders are usually expectant of, and usually they just take it as part of taking care of the welfare of the members. So those are some of the challenges I would say we experience generally, but I firmly believe the role of unions is still inherently the same as it were when this idea came up, because the balance has to be maintained somewhere. When you have a beam that puts the capital owners at the top and the labor owners at the bottom, then that is the very reason that unions will forever exist, not just in this country, but even all over the world.
All right, Senior, the unions, and you see it at the topmost, I would say, because the gentlemen that I have here are representing, different counties, I'd say, or different, perhaps branches. Lower the branches, rightfully said. What do you make of the unions and what you have done for their respective entities that you serve? I remember, and I'm sorry I'm using Panyako's name so much. So the other time as well, I was talking about unions at some point. There was even a tussle as to who really is the head of this very union. And you ask yourselves, if it's going to get to that point, will we really be objective in making sure that then you work for the employers, and that those are now the medics that are dependent on you for making sure that their issues are addressed.
True. And I want to agree with my brothers here in what they have said. But in a broader perspective, why do we have unions? Unions are an entrenchment of democracy. The reason why they were established is because workers had that push to be involved in their own governance at their workplace, and even how their workplace is organized.
Yeah.
So it came in as entrenchment so that workers can be able to voice what they think would actually be able to work for them. There's an American president, I cannot remember his name, who was asked, if you were to become an industry worker, what would you do? And he said, the first thing I'll do, I'll join a union, because he knows the benefits of the union.
Yeah.
Now, in health sector, the unions are very unique, because we cannot negotiate for us without negotiating for the patient. And the same applies when we are also calling for industrial action.
Yeah.
It's not only a balance between yourself and the stand of the employer. It's also a balance between the both of you and the patient who is suffering as you are negotiating.
Yeah.
And so in that line sometimes, and I like what they said about the balance, you have to balance between what you want as a union and your members, what the employer can be able to afford,
Yeah.
and the patients, the level of suffering that you're having with the patients. So the three things might tilt the balance, and that is why sometimes we get to compromise, because from where we sit, at some point you must be objective and look at what is the reality and what is achievable.
Yeah.
What have we been able to achieve with the unions, especially in the health sector? You realize that before 2010, the previous constitution did not actually allow medics to have unions. And health sector, our health facilities were in deplorable conditions. Since 2010, I'm sure you have realized that one, the welfare of healthcare workers has greatly improved. The healthcare worker before 2010 and the healthcare worker we're having today, they are completely different people. They can be able to live a decent life. Before 2010, that was not possible. We have also been able to bring out the issues and the challenges in the health sector, and this has helped the government to actually even appreciate and acknowledge and be able to uplift our healthcare facilities. Even the managed equipment service that we have and that sometimes we complain about came out of the complaints, and especially from, I think, the strikes of KMPDU, because they are our elder brothers. I think they're the first union in this sector. So if you look at even our budget after 2010, it has really greatly improved. And also unions in the health sector, they do not only serve their members. We also serve to educate the public about the health sector. They have the public actually, after the unions have come into place, they understand more about how their health sector is governed,
Right.
what they should demand from their leaders, what they should demand from the hospitals they go into, what their rights are, what is lacking, and who is actually responsible to ensure that they get the highest standards of healthcare as envisioned under Article 43 of the Constitution. So the unions in the health sector are very unique in that we don't only speak for our members, we also speak for the patients
Right.
that we actually do treat. So it has been very beneficial to have the unions. We may not have reached probably where we want to go,
Yeah.
but I believe that it's a process. But we acknowledge that actually unions have been able to change the health sector and to do the same for the better. About being politicians, being a unionist, especially in a sector that is managed by politicians, you have to be a politician. You have to learn to be a politician.
Right.
I remember sometimes in the previous government, the CS for Health once told me that I have turned into a professional activist. And I told him that is quite true, because I've been made to,
To be an activist.
a professional activist, and you'll see me even picketing out there.
Yeah.
Because as a union, you have to be innovative enough to look at what would then work in this environment of politics to ensure that the message you want to deliver actually goes through.
Yeah.
And that is why you have seen that as the unionists in this sector, we have had some times to even take political direction to be able to achieve some of the things that we have been able to achieve, not for only the good of our members who are the clinical officers, nurses, doctors, and the other health workers, but also to the mwananchi down there. When we are speaking about NHIF, we are not speaking probably about the welfare of our people. Whatever we are looking at is that good of that patient. Whenever we are talking about our working environment, ensuring that our working environment is safe.
Right.
That safety actually benefits more the patient who is coming to a facility because they are not going to suffer harm in terms of probably being able to get some of the, we call them nosocomial, hospital-acquired infections and what have you. You will be surprised to know that as we sit here today, the Occupational Safety and Health Act requires that in every facility you are supposed to have an OSH committee, Occupational Safety and Health Committee, to ensure that the environment is safe for both the patient and the clinician or the medic. But 80% of our facilities do not actually have that. The 20% that do have only had that after 2010 because of our push and struggle. And that is why as unions, especially now, I think the clamor has really been towards the remuneration. But I'm sure you are seeing now we are broadening our clamor and we are looking even at the environment that we are actually working under.
Yeah.
And that reminds me, and I hope we are going to come now to that, as we also go into counties, there are commitments that we made in 2013 that were made by the government. And these commitments were actually made to the World Health Organization in a Health Human Resource conference held by WHO in Brazil. And the reason as to why I'm saying this is because it was speaking to what actually should have happened. And if we didn't drop the ball at that time, actually I believe that health would be at a better place. And what are these commitments? The commitments then was that as we devolve healthcare, we would have what we call a Health Human Resource ICC, Interagency Coordinating Committee. The Interagency Coordinating Committee, which was supposed to be domiciled under the county and under the national government, was supposed to ensure coordination between the two levels of government. That is the biggest problem that we are having.
Yeah.
Because we don't have coordination. The national government will make the policies, the counties will refuse to implement the policies, either because they have no knowledge of them, or number two, they just don't want to be governed through these policies. Number two, the second commitment was that we had committed every year to employ 12,000 healthcare workers since 2013. Yeah. Understanding the gap that we actually had then. We have not been able to do that. I think we have not even employed 12,000 since 2013 up to now. That was supposed to be on annual basis.
Yeah.
The third commitment was on now the recruitment of what we are now calling health promoters, community health promoters. By then we had seen about 40,000 and eventually increased, I think, to 100,000. I think that one we are trying to do our best, though it's a bit late. And also how we are doing it is also a problem because they seem to think that you can actually replace medics with the community health promoters. The fourth commitment was about looking beyond the salaries and remuneration.
Yeah.
Budgeting beyond salaries and remuneration so that they can ensure that there is effectiveness and efficiency through promoting welfare, through rewarding those who have been able to do well. And the last one was about incorporating private-public partnerships to ensure that the health infrastructure is top-notch. Yeah. And this was supposed to speak to Vision 2030, where we want by the year 2030 to actually have Kenya as a medical tourism destination for Africa. Yeah. So that is where we actually dropped the ball. And I think that is what now the unions have actually been lobbying for. that can we be able to go back to the commitments that we did make? Because if we had the HRH ICC, we would be having these policies that are supposed to govern inter-county transfers, different levels of government, national and county transfers, the rotation of specialists, the internship, the welfare, the schemes. All these things would actually have been taken care of.
I will equate that to, and that is my assumption, collective bargaining agreements that are always placed on the table. You will agree with me that there are instances where the unions speak in different tongues, and that perhaps would, in a huge way deter or delay the possibilities of them, attaining some of these things that he speaks of that are very, very important. And so today, KMPDU speaks in a different language from what KUPO is speaking, and from the way, what I would want to call them NAN. Sometimes I've heard them say NAN, Kenya National Union of Nurses, They speak totally different. And so at this very point, who is to speak on behalf of the medics so that the collective bargaining agreements then are met if the unions are not going to speak in the same time? So the situation has changed. Has it changed?
I'll say this about medics.
And the unions.
Yeah, for the unions, we have different cadres.
Yes.
Based on our job descriptions.
Yeah.
We have doctors, nurses, clinical officers. Most of the time, you'll find that whichever they have different JDs, and as such, we end up most of the time having different specifications on what to do, how to operate, and how to manage our affairs. That's why we've ended up with different unions, like KMPDU for doctors, KNAN, and KUKO. Now, the issues he has talked about, it narrows down to what we call a Health Service Commission. What we're expecting is from the Health Service Commission, it will incorporate all the different cadres to get rid of these discrepancies that you're talking about.
Yeah.
So that when KNAN raises issues, or KMPDU, most of the time, you'll find KNAN maybe will talk about placement of nurses, specialization. It may cut across, but there are issues which are specifically for nurses. And then there are issues which are specifically for clinical officers and doctors. But at the end of the day, whom are we looking at? The patient. Okay. So what you're saying is, if we're able to get a commission, like he has talked about, the intergovernmental integration of both national and the county and at the county level, so that we have human resource. Human resource is now being managed by maybe a single commission. It will be able to address all these issues, so that when KNAN raises issues, they are sorted instead of having one union talking about the same thing which has already been addressed, which has already been raised by a different union. You get my point? Right. Yeah, so from our call for the Health Service Commission is to be able to incorporate all the cadres in health. Right. Yeah, so that we can be able to, at the end of the day, be able to sort the issues affecting human resource. Well,
fair enough. So, Okumo.
Yes.
Health as a devolved unit. Discuss.
Thank you. Yeah, so, 2013, 2014, that is when healthcare was actually devolved. But if you look at the Constitution, how it's actually put, they say health is actually a shared function. So it's shared between the national government and the county governments. So, sometimes we see the national government, whenever there are issues at the counties, they want to run away from it and throw the blame to the governors. And sometimes, honestly speaking, we also sympathize with the governors because we look at the burden of healthcare and perhaps the money they receive from the national government, and it's not enough. So when health was devolved, what was supposed to happen was actually also devolution of everything else, from the financing of healthcare, and that is significant financing, to the procurement of health equipment, to the HR. But what we saw happening was just devolution of majorly the human resource, which again, if you look at it in retrospect, you realize perhaps it was just an attempt to easen, this thing that we constantly hear, the wage bill coming from the national government. So devolution of health, in as much as it was envisioned to be a good idea and to improve the healthcare of the local Mwananchi, the Wanjiku, on the ground. I think to an extent that has happened because healthcare has been more accessible and management of healthcare has been okay, other than issues that relate directly with human resource. Because you realize counties, when they came in, perhaps they did not have the capacity to handle this human resource aspect. And initially, everybody figured that perhaps it was just a learning process and it would take some time before counties caught up. But today, from where we sit, we see the human resource aspect of healthcare to have been the least aspect or the worst performing aspect of devolution of healthcare. Why do I say this? You find that for the doctors, since devolution happened, you can literally count the number of counties, and they'll just be a handful, that have hired doctors, or even nurses, or even clinic officers. And those are numbers that are really low. And the reason the counties keep doing that, or at least what they tell us, is they do not have the money to do that. So it cuts across all the cadres that you find since devolution. We have the workforce that exists naturally, maybe through death, through resignation, or even looking for greener pastures and so on, but we don't have replacements. So what happens is you have severe shortages in all the counties, and for us we think that is where devolution has actually failed. So a health services commission, or whatever name that they might call it, assess in this financial year, and let's say Mombasa County didn't think so, yet you realize the same patients in Nairobi County have no much differences with those in Mombasa County. At the end of the day, we try to lobby for the patients. We are advocates for the patients at any given day. As a healthcare worker, your primary responsibility is to take care of that patient. So even before you join any union, automatically you become an advocate of that patient. You want to look at their well-being. So the moment you realize that the workforce is less elsewhere, but it is more somewhere because of the differences in county priorities, or the leader of that county perhaps shares a different vision, then that really compromises this aspect of the human resource. What a health services commission or any organization that can be formed in this regard will ensure is equity, number one, and proper accessibility of these services to everybody. So be somebody in Wajir, be they in Moyale or wherever, they are able to access healthcare, and also in good time. You know, healthcare is about accessibility. It's also about the time you spend at the queues. You don't want to go to a health facility and because there's only one doctor seeing a large number of patients, therefore it means everybody has to wait longer in the queue. Or the lists for surgery are too long, so that if you see a patient today, then you have to plan their surgery in a month's time, if it's an elective surgery, not the emergency. The emergency, they always have to be done. But if it's a surgery that you need to plan, then you need to plan it in a month when you could do it in a week. Just because you look at the number of patients that are presenting with different conditions and the available doctors and the nurses, and then you realize it is humanly impossible to do these cases as we would have envisioned to do them. So those are HR issues which we still believe that having a central body and looking at all this, also to add the issue of promotion. Like my colleague just mentioned, you realize there are those policy documents that sit with the national government and have always been with the national government. The other challenge we've seen with the devolution is that most of these policy documents do not percolate to the counties. And when they do, they're either ignored or not acted upon. Either because of incapacity, like he mentioned, or for some other reason we do not understand. Because we have nurses working in the national system, and clinic office, and doctors. And we can tell you that some of these small problems we see at the counties do not exactly present in the same manner in the institutions they work for, which are still under the national government. Like I mentioned, healthcare is a shared function. So we have those facilities in the national government, then we have those in the counties. So you'll realize most of these problems, most of them actually happen in the counties. So there has to be a reason for that. And it cannot be because of the healthcare workers, because one healthcare worker working in the county has the same qualifications If it's a nurse working in the county, they bear the same qualifications with the nurse working in the national government.
We have tried working and tried and tested, I'd say, with the national government, of course, right before the conversation of, devolution, and still things were not so good. Devolution was such a bad idea for health, I'm asking.
I'll say this. Devolution was supposed to have been the best for health, but it was poorly implemented. As envisioned in our constitution, what the counties are doing with health, it's not what was expected. Like when you look at the devolved departments or services, let's look at health and agriculture. When you look at health, a county like Nakuru has been able to implement its policies appropriately. In the sense that the Nakuru level 5, it's able to manage itself. So that money received goes now into human resource. I'll be very honest. Training one doctor or one nurse takes more than $1 million to train a nurse. So their payment or their salaries, our salaries are usually very, very high. So for most of the counties, they are not able to afford it. What happens? The services go down. So what you're looking at is we're expecting the governors to invest in health. If we're able to invest in, let's say, level 5, in the various specialty, like renal, ICU, and the rest, the facility will be able to run itself. It will be able to generate revenue. As we had discussed about the pillars of health, financial being one of them, you'll be able to get money from there. And then from the revenue, you'll be able to run the other facilities within the county. So that money which comes in, allocated to health, can go into human resource. Into human resource, which will involve payment of salary, trainings, and referral services. So devolution, if devolution of health would have been implemented appropriately, it would have really worked. Because what was envisioned is you're bringing services closer
to the people.
Take the example of CDF, the Constitutional Development Fund. It has been really, it has really opened up the country. So if health was devolved, the various structures at the various level, and the services are provided appropriately, wananchi will be able to access health, especially promotive and preventive. That is level 2 and level 3, where we're talking about the dispensaries and the health centers. With that, the prevalence of especially communicable diseases will reduce. With that reduction, it will be beneficial to mwananchi. But what we're seeing with the governors, most of the governors, they're not investing in health appropriately. They're focusing on purchase of medication,
Purchase of equipment.
No training. Right now, as we speak, there are so many facilities which are understaffed. As per WHO standards, we've not been able to get close to what the WHO has advised. We go back to the universal healthcare program. We have people who are employed, or nurses, especially nurses and clinicians, and are in a 3-year contract. Most of it ended in May. It was May 11th. With the government promising to renew. Up to date, it has not been renewed. None of them has been replaced. How do we expect to achieve healthcare with such kind of numbers? As Dr. Okumo has indicated, counties are not employing. Most of them, the complaint they're having is the resources. But how are they using the resources allocated to them? It's easier to put up a road for a governor than employing healthcare workers. So what we are saying is let the counties and the national government look at health in the appropriate way it's supposed to be and manage it appropriately. Because as we speak right now, reverting back to the national government, it's quite impossible.
Let's ask Senior that. What would be the wisdom here? To revert in totality, or just like it has worked for other counties, try and make that sure that health is working in other devolved units, because they are success stories for sure. When Kisumu, for instance, is on strike, maybe Nakuru, is working. Unlike those days when it was a strike was declared or was called, it was across the country. And so at least you can say, well, if in Kisumu there's a strike, you can take your patient and try and find your way to a different county so that they can get medical services. So we reverse or we try and make it work.
Yeah, I think what we have been saying as unions, and before I even answer that, let me talk about the unity in the health sector. We have what we call unity of purpose. We have a health union caucus, where as I think we are about 6 unions now, different unions in the health sector. We come together and we look at the matters of common interest that we can be able to address together. And I chair actually that caucus. And that caucus, now to answer your question, has looked at these things and even went further to propose solutions to the challenges that bedevil the health sector. We are not asking to go back to the national government. It had its own share of challenges when we were there. What we have been asking for is, can we go into a health service commission which is independent of the national and the county governments, the same way we have the Judiciary Service Commission, the Police Service Commissions, and the others. And we have gone further to even say that we can actually have a commission that respects devolution. And how do you do that? You can have a commission where it is the counties that requisite what they need from this commission. They say we want 2 doctors, 1 clinical officer, 3 nurses, and that is what the commission is going to deploy to them. And then they have some delegated human resource management responsibilities, like discipline and redeployment within the county. But when they need to terminate or otherwise, they return you to the commission, and so that you can also have the inter-county transfer. We can actually have a health service commission within the setting of devolution without even having to take health back to the national government, and it would work. The biggest problem has been the politics. When you say health service commission, then there is a red line dividing in between the healthcare workers in the unions and the governors. They usually say that you want to take health back. And it's a very sensitive issue. You even had them say that the national government wants to plow back because of the issue of how they are going to fund the primary health care, the primary care networks, and whatever they are shifting now from the National Hospital Insurance Fund, I think, to social health insurance. And they have been saying that they are plowing back. So what we did, as the Health Union Caucus, we decided, why don't we try and propose solutions? And for the first time in this country, last year in March, we were able to convene the Kenya Health Workers Annual Convention, we call it KEHWAC, that actually brought together all the players, because we said the problem that we do have is that we don't speak to each other. We have never come to a round table as all the players in the health sector. And so we convened the Council of Governors, the Ministry of Health, all the unions, all the associations, the partners. Actually, AMREF was one of the biggest partners, and NHIF that supported that convention. And in that convention, we actually discussed all the challenges, and we came out with recommendations in terms of resolutions. And it was a very high-powered discussion, because it was opened by the CS Health, then Mutahi Kagwe. It was, and the Chair Health Committee then, Excellency Professor Anyang' Nyong'o. It was closed by the CS Labor, then CS Chelugui, who actually even read out the resolutions as a consensus between the players. And one of it, because in realization that probably we are having fears, and we were not talking from the same page with the governors, we then recommended that can we then ask the president to have a presidential task force, a joint task force on health, so that it can bring all the players around the table, and they can look at the challenges and recommend solutions. The governors would say, we don't see the Health Service Commission probably as a solution. We see that we can be able to do this, because our aim is not a commission. Our aim is, can we have a conducive working environment that then facilitates us to be able to deliver the best service to Kenyans, and equally in terms of funding. The problem is, and I don't think the problem is entirely with the counties, because before this government came into place, we were actually able to meet the deputy president then, who is the president now, His Excellency President William Ruto. And I'm actually the one who handed over the document, the resolutions. And some of them were even incorporated. Even the 20,000 employment actually came from there. The issue of CBAs came from there, the resolutions. And one of the things that we agreed in that meeting was about this task force, so that it should come and give recommendations on how we will be able to solve these challenges. But then later, we actually wrote to the president reminding him that we need a task force. When I think there was a task force on police, then on education, and we realized ours was not coming. So we took the initiative, and jointly as unions, we wrote to the president. Then it was taken to the cabinet secretary. I think the chief of staff wrote back, said that it had been taken to the CS Health. That was sometimes in January or February. Up to now, we have not seen any action.
Wow.
So as the unions, I think we have tried our best to resolve the challenges that we do have. I think the ball is on the court of the national government through the CS of Health, because it is very important. The only way we will be able to cure the mistrust that we are having between the Ministry of Health and the counties is having a task force, so that people can sit together and they can say that we think you're having some cans under the table. What are you hiding? And that when we develop trust in between the Council of Governors and the Ministry of Health, that is the only time that you are going to see health working. You know, the other thing, the other thing is that we have the Kenya Health Human Resource Advisory Council. What I've heard from the president, we are really thankful that it has even taken the level of the president to be able to convene and to ensure that this advisory council is inaugurated to look at the policies that would actually be able to facilitate an effective workforce. But the expectation I'm hearing being spoken of that council actually is not within the mandate of that council. Because it is being spoken of as if it's replacing a health service commission. And that is why even I think the governors are having jitters. But this is an extremely powerless council that is only advisory in nature, that is only making policies, and we don't know how then the county governments are going to take up these policies.
I don't know why you think the governors are having jitters. It looks like there's a lot of money that goes there, that otherwise why would they have jitters? And that aside, like you've answered my next question. My next question was to, find out whether there's a lot of support and, agreement from the national government point, in terms of what it is that unions are pushing for. But clearly, then there's a problem that needs to be fixed. And you must have wondered why we didn't go to the next newspaper, which is Standard, your favorite. But yes, it's basically because almost all the stories are the very same ones that have been captured on these other ones. And now it was important in the essence of time that we get to the conversation itself. And so I will focus on the previous budgets, that is 2022-2023. And this I read, the very same spot, speaking about the budget estimates then. And, they said that Yatani gave the health sector its biggest allocation ever in history, and the CS allocated 146.8 billion to the healthcare sector, out of which 62.3 billion would cover the universal healthcare coverage of President Uhuru Kenyatta. And I remember then we kept on saying that now, well, the Big Four agenda has gotten, its best ever. The estimates this time around is that, again, health is going to get, the largest chunk amongst all the sectors, alongside the education sector. Why is it that this entity, health, will always get, the largest amount of allocation in any budget here, yet we still have some of these nitty-gritty and underlying issues. Why? Would go to you or either of the two of you. I mean, we're almost closing anyway. We have about 8 minutes. So we have to balance time as much as we can. Yes.
Okay, I could start, and I'll just be probably brief. I think one thing we need to appreciate is that healthcare is expenditure. That is one thing we need to appreciate. So most of the time we see policymakers look at it purely from the point of wage bill and supplies and all that, and procurement. And I think one thing that we have also seen is that we all need to appreciate that for us to have the highest attainable healthcare or standards of healthcare as envisioned in our Constitution 2010, because that is what actually we wrote in the 2010 Constitution, we must agree to spend on that healthcare, especially on public healthcare. That is the only way we can achieve that highest level. And it's good that the government has plans to improve the UHC program, has plans to hire more workers, be they community healthcare workers, and so on and so forth. But then the whole gist of the matter should be that we should not look at a ceiling of expenditure, because you realize the Abuja Declaration that brought together all African governments, sometimes in 2004, I think, if that is correct. And in this declaration, all governments agreed that they should be spending about 15% of their national budget on healthcare. There was a reason for that. You realize there's the per capita expenditure that developed countries use on their citizens. And then there's that which the emerging economies and the developing countries use on their citizens. So the 15% was an attempt to try and bridge and move towards the highest expenditure you can put per person in that particular country. And therefore the Abuja Declaration was made at 15%. You realize what we have in our country is much less than that. However, in the past 3 or so financial years, we have seen there's been an attempt to try and increase this budget. But then if you see what is actually increased in this budget is what I would call meager increases. And sometimes you wonder whether they are actually significant, because if you look at the issues of inflation and generally raised cost of equipment and all that, and the dollar rates, you actually feel that there might actually be no net effect, in as much as there's a difference of 2 billion or 1 billion between these 2 successive or 3 successive financial years. So I think that if we are to deliver proper health care to our citizens, then as a country we must be able to spend, and we must be willing to constantly aim significantly for the 15% as a start. If you look at the percentages, currently we are at about 5% or maximum 6% of expenditure. And the burden of that usually goes to the UHC programs. So that means, again, we need to look at ways of strengthening these UHC programs, so that if it is the health workforce that is needed, be they the community healthcare workers, be they the doctors, then there should be equitable distribution of this healthcare workers, so that you don't start a process with the community healthcare worker that you cannot complete with the nurse or you cannot complete with the doctor. It would be an exercise in futility. So we need to have a situation whereby all these healthcare professionals are recruited via the UHC. And of note is the terms of the recruitment. You realize most of the time, even we've seen it in the previous years, when UHC staff were brought in, it was contractual. So then you realize most of these workers, what really is in their minds is when are their contracts expiring. And you don't want to have people always thinking of whether their contracts will be renewed or not. You just want them to have peace and deliver that highest attainable standards of healthcare. So the funding of healthcare needs to be gradually improved, aiming for the 15%. And I think as a country, it is a burden we must pick up. Just like we want to see good roads, just like we want to see proper education. The same way, if we want to see a well-established healthcare system, then it is a burden that we must pick up and be ready to spend on.
Saka, that we acknowledge, but there has to be a justification as to why more funding. There has to be accountability on the previous, funding that has been accorded. Are we there? Are we at a point where we can bargain for more for the health sector?
Thank you. I would like to say this. We also need to, let's start by first looking at the budget and the allocation. Let's break it down. Where does majority of that budget go to? equipments, infrastructure. When you look at health, I'll speak as a healthcare provider. I would rather the government invests equally also on the healthcare providers. From the community health providers to the nurse to the clinical officers up the ladder. So what you're seeing in health is we are getting an allocation or a budgetary allocation which is way below what we're supposed to be getting.
Yeah.
Like in the previous budget, education, we're expecting education, security, and health to be at the same level. When you look at the money allocated to education, it was more than 500 million. It was more than 500 million.
Yes.
650 billion.
650 billion. Almost half of that went to the Teacher Service Commission. So when you look at whatever is provided in health, vis-a-vis whatever is in education, I think we are not able to achieve whatever is expected of us under the WHO goals.
Yeah.
UHC program, it was a very good program, but at the same time, its implementation, it was done poorly. As my colleague has indicated, the community health providers, are we able to engage them fully? Most of them are volunteers. They are not, even in the last budget, most of them are volunteers. They were not being paid. That is one of the justifications for incrementing allocation to healthcare. Healthcare workers, look at the dispensaries. We have previously the national government via CDF was able to put up very many dispensaries. We are doing a lot of infrastructure. What about the healthcare personnel? Are we employing them? So as we talk about allocation to health, let us also look at the healthcare providers, the human resource part of it. Because when you visit a hospital, you don't go there for to look at the infrastructure. You need a doctor.
Right.
You need a nurse. You need specialized care. When you look at our Department of Health or the Ministry of Health, it has two departments, medical and health. We're expecting them, under the medical part of it, emergency care in this country is really underfunded. So we're expecting the government to come up with an emergency fund, look into emergency care. So as they implement all these policies, they're all based on money. None can be implemented without money. So the allocation that we're having right now, as my colleague has indicated, it's way below the Abuja Convention, 15%.
All right, so sum it up for us, and that in relation to the allocations, and certainly would expect more of it, but is there a justification? Is there accountability for what has been accorded and what way forward? Because like you started by saying, there are pillars to it, to making sure that it's a success. ICT, very, very important. Financing, you acknowledge, is very, very important. And so in all this conversation, if there's no proper financing, then perhaps we're not headed anywhere as we close it.
And very true. The health sector is at crossroads. We are at a situation where we are seeing experienced medics seeking to work in other countries, and they are leaving this country. I have a friend who has worked in KNH for more than 15 years. Now they are working in US, and that's a story for many of them. You're also looking at a situation where the counties do not have the capacity and the ability to employ because of two things. One, they don't have enough money. Two, they have reached the ceiling of recurrent as per the PFM Act. And that is why you are seeing the national government employ and deploy, like in the case of the UHC contracts. And we thank the government because that was a good thing. Number three, the mistrust and the disagreement between the two levels of government. So as we go forward, I think it is incumbent on this government, because they had promises they made about health, for them to find a solution so that one, out of the 6 pillars of the 6 pillars of the healthcare system, the most important is the health human resource. That information you're talking about, information systems, requires human resource. That financing requires the health system managers who are health workers. There's service delivery, the essential medicine, whatever pillar you talk about, it must be moved by the human resources for health. If you look at our projections in the staffing norms and standards, we are not even doing 50% of what we Kenyans and under the Ministry of Health had projected the numbers we needed by 2018, not even 2023. Like for clinic officers, by 2018 we were supposed to be 16,048. Right now, we are about 7,000. We are not even 50%.
Not even half. Yeah.
So unless we have deliberate measures, and I like when the president says we need to take deliberate measures, I think it's about time that the president takes deliberate measures in the health sector, and especially regarding the health human resources, so that we can also have annual recruitment of health workers in their right mix. If we have annual recruitment of health workers, as was envisioned, universal health coverage, as we want it to be. But if we are going to continue with the rhetoric, I've seen that the increment now is 8 billion from last time.
Yeah.
And I think we say, Mgala muwe lakini haki yake mpe. There are two things I've seen that are very encouraging. That we have now budgeted for emergency services fund. That was not there. It is going to help such that when somebody gets an emergency, they are treated in a certain facility. They can actually claim. The second thing is about the digital health. Has also been given some vote, and that will mean that we are going to see now digital health improving, and probably in future we will be able to utilize it to make health more accessible to the population. So my parting shot would be what I said, that in looking at the solutions, I would still wish to request the Cabinet Secretary for Health that she can be able to constitute that joint task force, so that going forward, you know, we have done a decade under health. We must be able to have a task force that would be able to audit and give us recommendations, so that we don't carry forward with the challenges that we had over the past decade.
Or perhaps have lots and lots of recommendations that are not being addressed. Peterson Wachira, HSC National Chairperson of KUCO, that is the Kenya Union of Clinical Officers. Thank you so much for speaking to us this morning. And right next to Peterson is Charles Okumu, the KMPDU. This one is a mouthful. If we start saying that medical practitioners and dentist union, I think it will take us forever. So the chairperson, Lower Eastern, thank you so much for speaking to us. And lastly, Michael Saka, the Kenya National Union of